I need to turn on screen around. Let me do that right quick.
All right, good morning. We're going to try and get started. Buenos días, vamos a empezar. Vamos a tratar de empezar hoy. Feliz viernes, happy Friday. Y antes de comenzar, voy a compartir alguna información y nuestros intérpretes también nos van a ayudar. So before we get started, I'm going to share some information on our screen, and our interpreters have a brief announcement.
Thank you. Buenos días a todos. Los organizadores de este evento tienen la firme determinación de facilitar la comunicación bilingüe en la reunión de hoy. Mi nombre es Mosh, mi cointérprete es Emily, y estamos representando a la Cooperativa de Justicia del Lenguaje Tilde. Estaremos ofreciendo interpretación simultánea de inglés-español y español-inglés. Good morning, everybody. The organizers of this event are firmly committed to facilitating bilingual communication in today's meeting. My name is Mojde, and my co-interpreter is Emily, and we are representing the Tilde Language Justice Cooperative. We'll be providing English-Spanish and Spanish-English simultaneous interpretation. Si usted se unió a la reunión usando su teléfono, favor de asegúrese de entrar con el app de Zoom para poder acceder a la función de interpretación. Esta función no está disponible en los Chromebook. If you joined on your phone, please make sure to join on the Zoom app so that you can access interpretation. Please note that interpretation is not available to Chromebook users. Si usted no es bilingüe español-inglés, puede seleccionar su canal de idioma haciendo clic abajo a la derecha en su pantalla de Zoom, en el globito si usa una computadora o en los 3 puntitos si está conectado por teléfono. Seleccione interpretación, luego español y luego picarle en Done o finalizar. If you are not bilingual Spanish-English, you can select your language channel by going to the bottom right-hand corner of your Zoom screen, click on the globe if you're using a computer, or the 3 dots if you're connected by phone, and select interpretation. Then click English and click Done at the end. It's important to activate this option if you are not bilingual, as some participants may speak in English. Digo, en Spanish. Algunas pautas para crear un espacio multilingüe. A few guidelines for creating multilingual spaces. Yo estoy hablando rápido porque estoy dando la introducción en ambos idiomas, pero ustedes, por favor, no hablen muy rápido. Eso pasa especialmente cuando uno esté leyendo una presentación o emocionada, nerviosa o al tener poco tiempo. También si no están hablando, por favor, pongan su audio en silencio. I'm speaking fast right now because I'm doing this introduction in both languages, but y'all, please don't speak fast. This happens especially when reading a presentation or excited or nervous or running out of time. And if you're not speaking, please mute yourself. Por último, les vamos a recordar que por favor hablen una persona a la vez y en un idioma por oración. Lastly, we remind you to please speak one person at a time and with one language per sentence. Estos espacios se crean con el apoyo de todos. Por favor, comunique cualquier problema por la ventana de chat o habilitando su micrófono. Gracias por crear este espacio multilingüe. We create these spaces with everyone's support, so please communicate any issues by chat or turning on your volume. Thank you for creating this multilingual space.
Thank you so much, Mojde, and I welcome everyone. So if you are having any issues with interpretation, please send us a message over the chat and we can help. Si alguno de ustedes tienen alguna dificultad en acceder a la interpretación, por favor, mándenos un mensaje vía chat y les podemos ayudar. This morning, I'm super excited to welcome both of our guests. This is our last state in our sessions for our state-by-state encuentros, where we've been meeting and inviting health departments along with community members to share what is happening in their states around the Ending the Epidemic plans, but also how they're engaging with Latinx communities and how to better resource our southern states. And so I'm delighted to have Mississippi here with us. Mississippi is one of my favorite states. I often fantasize about moving to Mississippi and buying homes in Mississippi. So I'm really excited to hear more about what is happening there. And we're joined this morning by Mel Bender, who is the director of the director of STD and HIV for the Department of Health in Mississippi, and also Selma Alford, who's the language access director with the Office of Preventative Health and Health Equity. And so I welcome them both, and I turn it over to you, Mel.
Mel, you're muted.
Good morning. I took my camera off and forgot my volume, my mute. Good morning, everyone. I have prepared a short presentation in an effort to give just a snapshot of what is going on in Mississippi. So let's see if I can share my screen here. Oops, start from the beginning, why don't we? Okay, is everyone able to see the screen?
Yes.
Okay, good. So on my first screen, if you notice, I have the 40 years of progress logo. What many people may not know is that June 5th marked 40 years since the first HIV/AIDS, well, the first AIDS cases rather, were diagnosed in the United States. So we have actually been dealing with this disease for 40 years. In commemoration of the 40 years of progress towards ending the HIV epidemic, there are 4 components that we are asked to take as a mantra to ending the HIV epidemic. That is reflect, recommit, re-energize, re-engage, and is referred to as the 4 for 40. So what is ending the HIV epidemic? In February 2019, the Trump administration announced a bold effort that would focus on ending the HIV epidemic, because if some of you know, currently we have approximately 40,000 cases of HIV that are diagnosed every year. That's 40,000 too much, too many, that's 1 too many. So the goal of ending the HIV epidemic spans 10 years. So we started in 2020, the announcement came out in 2019. And in 2020, the goal was to decrease the number of HIV infection rates by 75% by 2025 and by 90% in 2030. We recognize, as well as our funders and the Biden administration, is that this timeline is going to be significantly impacted by COVID. So we're waiting to see if we're going to get new information that will allow us to move the timeline a little bit. We do anticipate that we will see a decrease in HIV infections from data that we have from 2020, simply because a lot of people weren't getting tested. So what does HIV look like in the United States? So all of this is based on 2018 data and information, because when the EHE initiative was announced in 2019, they were using 2018 data to serve as a guideline on what we will do to end the HIV epidemic. So in the United States, 1 in 7 people are living with HIV, but they are unaware of their infection. More than 700,000 American lives have been lost since 1981. At the end of 2018, an estimated 1.2 million people aged 13 and older were living with HIV in the United States. And again, as I mentioned earlier, an estimated 40,000 Americans are newly diagnosed each year. The estimated costs related to HIV care and prevention in the United States is upwards of $20 billion. And unfortunately, young people are the most likely to be unaware of their infection. So the EHE program or initiative is being released in 3 phases. The first is geographic focus. That means several jurisdictions have been funded to support this first phase, Mississippi being one of them. Phase 2 will be a wider dissemination of resources, and phase 3 will be implementation of intensive case management. The idea is by 2030, with the significant decrease in annual HIV infections to approximately 3,000, we will just be helping to manage those numbers of people who are newly infected with HIV. So there are 4 pillars to the EHE initiative: diagnose, treat, prevent, and respond. Here I've included the map, which reflects the jurisdictions that have been funded for the geographic focus of this first phase of the the Ending the HIV initiative. And these are the priority jurisdictions in Mississippi. So the health department was funded through the Centers for Disease Control and Prevention, as well as Health Resources and Services Administration, more commonly known as HRSA, through our Round Light Part B program. There were also 6 counties that received funding in Mississippi: Forest County, Coahoma, Harrison, Bolivar, Jones, and Madison. So when we were developing a plan for the EHE initiative in Mississippi, one of the things we had to take a look at is what would it look like in terms of trend analysis if we were able to reach our goal by 2025. So we haven't stretched out to 2030 yet. So one of the things that has actually happened, if you see here, last year in 2019, we had 480 new HIV infections diagnosed in Mississippi. In 2020, we had a projected goal of 409, but we had only 376. Projected goal for the health department was 409. Projected national goal was 375. And as you can see at the bottom with the asterisk, we actually had 376 new diagnoses of HIV for 2020. We are still cleaning the data. We may, and I put an asterisk because that number may change, but right now it looks like we're on our way. So in Mississippi, when speaking in terms of the Hispanic and Latinx HIV diagnosis here, as you can see, the rate is 36.8% in the state of Mississippi. When we ran our data, it was determined using CDC information, and here, 347 of the Latinx diagnosed in the United States were at a rate of 473.4 per 100,000. That's significant. It's also significant in Mississippi when you compare the population rate. So here is a snapshot, and this information can certainly be provided later, of data that has been compiled by the CDC representing rates among demographic data among population groups within the Hispanic population, So in 2018, 27% of the new HIV diagnoses in the United States were among Hispanics and Latinos, and most of them were among gay and bisexual men. So I won't go through this infographic in detail because this is information that can be provided to the group later. So in Mississippi, this is a snapshot of what we're looking like among whites, Blacks, and Hispanic and other populations. And where there is other, oftentimes that is someone that has not reported that they are assigned to a particular race or ethnic group, and that data just ends up being missing. So as you can see on our map, and I was able to go ahead and have data generated for 2019, we're not through cleaning the data for this piece for 2020, but as you can see, there has been a dip in the rates by race in the Hispanic population over 2018. So in 2018, there was 23.40 per 100,000. And then so far from the data we've been able to glean for 2019, there's 17.4 rates, 17.4 per 100,000 in the population. So some other information, and I don't want to go overboard with the data. And one of the reasons why I would probably want to pause here is that we are still learning and gathering information as a result of the EHE initiative. As the years have gone by, there has been an attempt and conversations about involving the Hispanic and the Latinx community in helping us develop plans on how to address the needs in the community. The EHE initiative says this is something that we must do. It can't be a group of people sitting around the table having a conversation about the needs of certain population groups without having those population groups at the table. So in June, on June 2nd, 2020, as part of EHE planning, we held a Latino leadership consultation. There weren't a lot of people in attendance, but despite that, there was a wealth of information shared to give us direction on things that we should consider as we're putting forth ending the HIV epidemic plan. I have an asterisk here by this first comment where Mississippi has the highest rate of HIV in Latino Hispanic communities in the entire country. This was a comment made by Dr. Leandro Mina, who is now in the STD director at the Centers for Disease Control. But last year he was still in infectious diseases and the School of Population Health chair at the University of Mississippi Medical Center. So other things that came out of that meeting included we needed to develop strategies to address specific HIV services within this population, use appropriate terminology, consider issues around the Black, Latino, Hispanic racial divide, consider social justice best practices, understanding not only the needs, not only the services, but what our approach should be, and whether or not certain representatives from the health department or within the community are those people who should be initiating or establishing certain community connections with the Hispanic and Latino population. Identification of the population to ensure allocation of adequate resources. This is critically important. With the border raids and other issues going on with immigration status, what we find is that people are often reluctant to get tested or enter any establishment where they might have to have documentation of whether or not they should be in the United States or be in Mississippi. And so considering that, we recognize that the data that we have, that we've collected so far, likely does not paint an accurate picture of what HIV looks like in Mississippi or in the United States. Oftentimes, we have heard, and we heard during this leadership consultation, that other organizations often benefit from providing services or working with the Hispanic and Latino population, but they don't take time to learn about their pain. And this was important to hear because when we're doing the same type of work in the African-American population, depending on who the messenger is, this is something that is echoed throughout a number of meetings. And so it's interesting to hear that that is also a primary concern within the Latino and Hispanic population, because it gives us pause to say, what works for some groups of color does not work for all groups of color. Considering discrimination and colorism, and finding a way to help uplift voices rather than address as saviors. And this is from the people who have these organizations that are not involving people from the population group, but basically just providing a service without necessarily understanding if the service is something that they need. Addressing health disparities and health inequity. Also at the top of the list is stigma and discrimination, which is a critical point and something that we need to strategize about in the EHE plan for all population groups, but certainly for minority groups. And then considering those who are uninsured or underinsured. For example, care and treatment through the Round White Part B program. We have very few people of other population groups who are getting access to this service. We really need to figure out how to get the service to the people who need it. They may know that it exists, but there may be some other barriers to accessing the information about the Round White Part B program, where people can actually qualify to get their medication for free. Also qualify to receive other services that are not directly related to their HIV care and treatment. So we need to partner with all of our population groups, but specifically at the health department with the Latino population, to be sure that as we implement and move forward with the EHE initiative, that they are no longer left behind. So I put here on my last slide, community engagement with a question mark, because I don't have the answers to this piece. This is where we hear from the community about what community engagement needs to look like as we bring to the table the voices of the Hispanic and the Latino population. Thank you.
Thanks so much, Mel. And now we'll turn it over to Selma.
Good morning, everyone. That's a very tough act to follow. Mel, awesome information. And I believe you ended out in the perfect point for me to begin. I'll be speaking to you and to everyone today in terms of what has the health department been doing to address those needs for the Hispanic communities, for the Vietnamese community, for other minority communities that we have in the state. We often highlight a lot of the Hispanic community, but as we move forward with finding different data, resources, and other organizations, we realize that there's more than just Hispanics and Vietnamese in our state, and they're rapidly growing. So at the beginning of the pandemic, when COVID-19 hit, the health department hadn't done any studies in terms of the numbers in our state for the Hispanic community. We haven't had a proper data analysis. I believe the last time it was 5 years prior to that, 5 years prior to 2019. In 2019 is when the Office of Preventive Health and Health Equity decided to move on and create a health equity department and implement the language access piece, which is directly where I fall into it. And it was extremely timely. What we learned during that first month of the pandemic, during March, was that the communication wasn't available to our community, and how to work towards making sure that we provide the community the needs that they were seeking for. Like Ms. Mel just stated, community engagement is a key part. And how do we find out what is needed from the community? We often, as educators, we often can make really good assumptions of the need of the community, but that does not mean that we are accurate. So we quickly started working with nonprofit organizations, churches. The very first Hispanic task force was compiled by an MD, a doctor in medicine, because of course we needed some guidance and direction on how to provide that information to the community of their needs, to kind of give a little access to their needs. We also went ahead and had an epidemiologist to try to help us keep those numbers, keep that information going. A healthcare educator, and a nonprofit organization which is I usually say IAJE, but they love the word EHE, which I think is very catchy. And with that small group, we started building education, making sure that we reached all the communities, all those different little pockets of communities to deliver PPE. Because if we look back during the beginning of the pandemic, we remember how difficult it was to obtain a mask. And those access was available to the community. It was just not getting to those people that actually needed it. So, and we moved on and transcended on also testing, making sure that they got tested and educated. I don't know if anybody remembers the different myths surrounding how painful and excruciating was the testing. So to go ahead and get the community engaged into testing and have some sort of trustworthy that we weren't going to harm them was extremely difficult. We also made sure that we started conducting town halls. With the town halls, my goal was to purposely deliver that information in a language that is understood by the community. What does that mean? Having access to that information in your own language. If you are in another country in the midst of a pandemic, not able to speak that language, and the government, the medicine, everybody's giving you information, but it's giving it to you in a different language than what you speak, that information is going to go through here. You're not going to capture it. So providing those town halls in Spanish was a must for us as an organization, as advocates for language access, and making sure that we provided communication autonomy. Because if the language wasn't there, the barrier was already there. So we were just adding on to it. So we began with town halls and educating, making sure that state health officer was present, because not often we see a person in that category, in that stature, actually address other communities other than the English spoken, in order to try to build some trust. Because when we look at the health department and then we look at the Hispanic communities, there's already a mistrust because it's a state agency and they're dealing with so much immigration issues. So trying to make sure that they know that we're actually there to help. Another key thing that we decided to implement, and Dr. Dobbs was so awesome in supporting every decision that we have made under health equity, was no proof of ID. Whatever you tell me, that's what we're gonna take. No proof of social security card, no need to even have an actual address. So during those testing sites, during those vaccination sites, we make sure that the community comes across as, whatever you tell me, we're gonna give we decided not to follow other states. Other states, we are aware that in order to get tested or in order to get vaccinated, they ask a little bit more information. And I know that sometimes we're looking to support data and stuff like that, but at this particular time, this is a crucial time for everybody. So what we decided to do is take your word as it is. And if you tell me your name is Juan Pablo, that's it. If that's all you want to give me, that's fine. If you want to make up a date of birth, that's fine. If you want to put the address of where we were at, that's fine. I know we got a lot of backlash initially because we utilized the National Guard for a lot of our testings. Unfortunately, we were under state of emergency, and during that time, what it was offered to us for us to go ahead and go to different areas was the National Guard. What Health Equity did and MSDH supported was contract other healthcare clinics to go ahead and help us out with testing and vaccination. What they also accepted was allowing those individuals from the National Guard to be able to be out of uniform while we were assisting the Hispanic community. That was hard to accomplish, but very achievable. We advocate. Our job was to make sure we provide the access, not to, bring more harm to what was already there. So kind of being mindful of that. Like I said, moving on, it was basically ground roots effort, working with nonprofit organizations, because they are the ones who's working directly with the community. Getting to know those church leaders was a very key part of our job, because the people go to church, we go to church, and that's what we trust. So aside from that, working with other organizations such as LavaLink that has created their whole view have been working with the Hispanic businesses to try to infiltrate that community, and working with La Noticia, because even though we were using the platform of Zoom for those town halls, let's be quite honest, throughout that time, nobody is internet savvy. So what to do regarding that? What we did know was everybody in the Hispanic community are able to log on to Facebook and are able to, they communicate with their families. They know what Stream Live is regarding of your age group. So we partner up with La Noticia and use their platform to be able to stream live those town halls to reach the community, because even though we have 20 people right here on Zoom, in that moment, we had 50 people on live on Facebook, and then they were sharing that information. Once again, our goal was to provide the information to the community from a provider that was reliable, because as we all know, during that time and still going on, there's so many myths going on between vaccine hesitancy, COVID-19 testing, including mask wearing, something as simple as that, as well as trying to make sure we give some sort of guidance for the parents on going back to school. How would that look for your child? And what can you do to make yourself feel safer that your kid is going back to school, or different techniques that they can use when studying at home virtually, how to get some resources. So that has been our mission throughout this pandemic, in our reach towards the community. And I will say this, throughout all that education, we did do a lot towards COVID education, but we also added the component of HIV, cancer, tobacco, heart disease, because as we all know, it all collides into one. It becomes one as a whole. If you didn't have certain issue prior to the pandemic, you most likely would have some issues after the pandemic. So how to treat yourself, how to become more healthy as an individual moving forward after COVID, because ultimately we want a healthy body. And COVID will knock us down a little bit if not taken. So please go out there and get vaccinated. We are still currently advocating more than ever about vaccination. And we are working towards a new town hall regarding Delta variants and other different variants, vaccine hesitancy coming up in September via Zoom. So stay put for that. I believe that's it for me. Is there any questions?
Thank you so much, Selma and Mel, for that such informative information. And we're so happy to hear. I think, as Jose put in the chat, not requiring identification and really trusting community with the information that they want to share with some of our institutions was game-changing. And I think it's super important, especially for communities who are also from the LGBTQ community, right? Trans communities who want, and non-binary, who want their names and pronouns listed, how they identify. So that's amazing. I'd like to explore more, how you all were able to, I guess with the National Guard, make those changes to ensure that community felt safe. And I love this, like, unifying other, treating people as whole people, where you were also including other health information and screenings during some of this. So can you share more? Mm-hmm.
Yes, of course. The National Guard, that was a very big beast to tackle, to say the least. What we did do initially before we started our testing, we conducted a town hall, and we sat down and educated the community of the efforts for the National Guard. What does that imply? Because we were conscious that the uniform sometimes, even though it does not represent ICE, colors are very similar, and hesitancy, alarm immediately starts going on. So we started with the educational piece, and the National Guard allowed us to go ahead and bring a couple of their sergeants that were bilingual to speak on the different stuff that they do around the community, centered around the community. So we started with that piece, and we started working with the different mayors and spreading the words, started talking to the churches. And then we moved on with taking it a step further and having Dr. Dobbs speak to whoever was in charge in the state of Mississippi for the National Guard to see if there was a way that they can go ahead and remove their uniforms, wear regular clothes for those testing sites and vaccination. A lot of times it was told that it was not possible, but as much as you push and as much as the need is there, and there's evidence base that, the community will not come out because of it, the needs outweigh the no's. So at the end, they were allowing them. So.
Great, thank you so much. And Mel, I did want to ask, I think that we saw that there were some changes in how folks were engaging with the health department and changing in numbers. And so can you share a little bit about how COVID may have impacted how people engaged with HIV and treatment and prevention services?
Yes, so the immediate, I guess what was startling for the community was many of our clinics, including our Crossroads STD clinic, had to transition from walk-ins to appointments. And not just appointments, decreasing the number of people who could be in the waiting area, have people sign in lists, get a call to come in. And what we ended up doing after having that as part of what was happening in our STD clinic, which is located in Jackson, in the Jackson Medical Mall, is I had a conversation with Dr. Dobbs early on when I got here about one of the things that I would like to see happen. And it happened to be having a virtual clinic or telehealth services for STD services, primarily because I used to work at the University of Mississippi Medical Center and with Dr. Mena, and we had transitioned to, when we could, offer telehealth services. And the Crossroads STD clinic being, it used to be called 5 Points, and it is the first and oldest, the first STD clinic in the state of Mississippi. It's very comprehensive, and for it not to have those services available. So in February of this year, we did launch not only our virtual clinic for STD and HIV services and referrals, but also teleprep. So that was a step in the right direction. However, what we've seen is, as you know, COVID, I don't want to say wanes, but when we had that brief moment where people could re-engage and be out, we still didn't see an increase in the number of people who are being tested, not necessarily in Hinds County, but in some neighboring counties. And I say that because we have seen an increase in syphilis. And in our community, in our clinical community, and STD HIV community, when we see an increase in syphilis, we know that we're soon going to see an increase in HIV. So during this point in February, we also started establishing our contracts with a number of new community engagement partners. And one of them happens to be the Immigrants Alliance for Justice, which we are completely excited about. And I've learned so much just in the few conversations that we've had with the group. And there's an opportunity to certainly expand. We are partnering with the ACLU, transgender non-conforming groups. Most of them are grassroots organizations that have not received funding from the health department before. And so that is something rather new to us. And it's important that I always say that EHE has made it possible for us to be able to do this. There are a number of grants within our STD HIV program, but they have a pretty set list of deliverables. Although there's room for innovation, there's some things that we really have to stick to. But the EHE initiative says nothing is off the table. Anything that you can think of that's innovative, if there's an intervention, use these new community engagement partners as the people who can speak most about the needs in our populations. The health department has formed the EHE task force, and it is going to be a group based on what it looks like now. It's going to change slightly. In our conversations with our funders, we have to expand beyond the normal members that we have that usually congregate around an HIV or an STD initiative. We have to be broader thinkers in that regard. And we have to consider that some of the needs that we have outlined in our services may actually change as the EHE initiative evolves in Mississippi. Although we have an EHE plan, it is not set in stone. It is intended to be fluid. So as we learn new information, as we branch out and engage additional partners, we may find that the partners that helped us put together the first plan may look entirely different with the next phase of the plan. And I'm hoping that that will be a plan that engages more of the target populations, people of lived experience, that will help us paint a truer picture of what our EHE initiative should look like.
And Mel, if folks wanted to get involved with the EHE task force, how could they do that?
Contact me.
Great.
Contact me.
That's great. We have a question from the chat, and it says, and I think it's for Selma, they wanted to know more around La Noticia and this Spanish news outlet and how that alliance worked throughout, and what intent you have in continuing this partnership with them.
That's very, very good question. So La Noticia is one of those electronic source of providing news to the Hispanic community of what's going on in the state of Mississippi. They do have a website. They also do a lot of informed information through their Facebook page. So how did they help? La Noticia correlates with also a nonprofit organization, which is MIRA. What they have done throughout this dynamic of the pandemic has been help us reach those churches, provide PPE to the community, as well as help us assist us with vaccination efforts. And that has been through Forest, Mississippi, Canton, Carthage, Meridian, and right now we're tackling Laurel. And it's been a conjunction with Jackson Free Clinic as well. They have helped us in several things, such as spreading the word, making sure the community is informed. Will I be continuing partnership? I am part of the health department. What does that entail? It entails that we take assistance from any and every community member and organization, rather if it's profit or nonprofit, to reach the community, because we are here to assist and help the community in every way needed. If you are an avenue for the community and you want to work with us, we are welcome all the assistance, because as we know, we cannot do this effort by ourselves. Definitely not. I know I couldn't reach as much community members as I've reached by myself. I myself is just one person, and we need the help of community members and organizations that are actually working with the community. So we partner up, like I said, with EHE, El Pueblo, MIRA, La Noticia, Mercy Housing, Bo SOS, Magnolia Medical Foundation, Lava Link, different organizations that are working with the community in order to get to the community. And that's our main objection.
Thanks so
Judith Snowbird, I did want to add something that is new for us is partnering with the Office of Preventive Health and Health Equity. So, you know, in our program, we often speak about health disparities and health equity. And here we have an entire department devoted to that. So being in a place where we don't have to look outside for this type of, you know, support and partnership as we try to, you know, reach those groups who we have not been able to reach successfully. I think this is, you know, not working in those siloed spaces is a new path for us. And so with, you know, having Selma here and, you know, Chigo and that whole office, we're looking forward to our own partnership within the health department as we try to address some of the needs in the community.
I agree. I think having an office sort of dedicated really shows where the health department isn't making those investments. I think there was Mississippi experienced in 2019 immigration raids, and they were really devastating to community and created a lot of distrust. So can you share a little bit about how that impacted some of y'all's work and how that has impacted some of the relationships you all are working so hard to foster and nurture in community?
Do you want me to tackle that question first, or would you like Mel to tackle it?
No, you can go ahead, Selma.
Okay, thank you. It impacted a lot because, as I previously stated, when we think about state agencies or anything related to the government, the immigrant community associated with the information being given to them is going to be forward to ICE or immigration. And during the pandemic, I think during that ICE raid, I believe one other state had put out a law out there saying that, you know, if you get pulled over and you didn't have any papers, they were going to report them to ICE. So it was one of our neighboring states. So it kind of just hit us straight on. So with that being said, what we have done as the health department is showing our faces. Health equity does not have anything to do with immigration. However, example, if they have a candle vigilant for those individuals that were rated through ICE, my face will be shown. I will say a few words because our job is to show proof that we're there to help. And if we're hiding behind an office, we're not gonna get that message across. We can speak about it, but if we show tangible proof and evidence to the community, makes a very, very different world of a difference. I'm sorry. It impacts. They actually can see that the efforts are being done. In the beginning of the pandemic for testing, we will go to the testing sites targeting those Hispanic communities, and we will get 5 people to get tested. Out of those 5 people, 3 of them would say that they did not come because they saw the National Guard present. So what did that mean for us as advocates, as workers, community workers? Meant to go back and explain that and enforce it to our state health officer so we can make a difference, because the fear was real, the fear was present. And as a Hispanic Latina fellow, I might not have endured what they endure, but as a human being, I can completely relate. I don't have to be Latina. I don't have to be an immigrant to not understand the pain and suffering that those families felt. So making sure that we properly advocate to our superiors in order to make a difference has created a complete different impact because we were battling with hesitancy against testing. Aside from the whole fear that it was going to hurt, now you have the fear of there's somebody there in uniform, or they're going to report us to immigration and we're going to go back and we're going to endure the same troubles. And so let's just not go. I'm just sick, and the disease still continues to spread because they don't know if they're positive or negative. That was one huge hurdle. Second huge hurdle we had, how to contact them, because the cell phone number that they provided was either not good or not real because they didn't trust us. So following up for those COVID-19 calls to give them the correct information was extremely difficult. So as we moved forward and they saw their own people being present and actually trying to assist, made a huge difference. Third difference was language piece, because we have already covered all two fears. Now they don't understand. So they definitely wasn't going to give you the correct number. Making sure that the person called doing the follow-up call is actually Hispanic made a huge world difference. We could have interpreters present, but they're still just interpreting. So what we did was create a whole area where all those follow-up calls were being conducted by bilingual staff, so we can go ahead and promote some sort of trust within the community. The information was being given right. The information taken was receiving right. So little by little, we have built up to now that we'll go ahead and do a vaccination site. Example, I did one at one of the local grocery stores. Those are places that Hispanic really go to. If you go to a Hispanic grocery store in Mississippi, you're gonna only see Hispanics. So making sure we target those areas that we know we frequent and getting a good products. During that vaccination, I had 30 people pre-register because of fear of providing their information. I had a total of 120 people show up to get vaccinated, and it was extremely hot. But they came and showed up. Second dose, they came and showed up. Once they seen that it was actually our people conducting those efforts, that the language access piece was put in place, they came out and it started taking part. So those are key things that we have to make sure that we continue to advocate. And when we talk about the language access piece, also making sure that those people that are interpreting are actually qualified people to interpret, have actually taken some sort of course to interpret. So making sure that we do have those thoughts and minds. And the state of Mississippi, through the health department, we didn't stop doing those interpreting course training because we are well aware. We have staff that are doing a lot of COVID related work. We are very aware that we have community members that are volunteering to make sure that their family members take part on vaccinations or getting to the doctors. So making sure that we continue to teach them how to conduct interpretations and remove ourselves from allowing children to do interpretation is a major, major step. Something that we constantly and often see, not keeping in mind that can go ahead and hurt that child for the rest of their lives. If they come in an encounter where you're giving horrible news to the parents, if us as an adult can't provide that information, it's hard for us to go ahead and say, hey, you have cancer. Imagine a child informing their parents, you have cancer, you have HIV, those tangible things. So I'm sorry, Mel, I kind of took over. I get passionate on that subject.
Look, I can relate. It's difficult to think about the ICE raids that have taken place and the subsequent impact that it has had on the Hispanic and Latino community. In anticipation, no one could anticipate what that would lead to healthcare wise, receiving services, even the impact it has had on the economy. I said earlier when I was presenting some of the data that, we do recognize that the numbers that we have it's impossible for it to be accurate, simply because based on the population in Mississippi of the Hispanic and Latino groups, we have so few people who are actually being tested for HIV, so few people who are actually accessing our services, being enrolled in our Round White Part B program, because a lot of these pieces require some form of documentation, right? A driver's license, an accurate address, a phone number, contact information. And, sometimes, it's not just some of the people or issues that Selma mentioned. We have it with different groups not leaving accurate contact information to get their results or to be contacted to receive other resource information. Years ago, when I worked at the health department, we had a mobile clinic, and we used to take that mobile clinic out in the middle of the night to Hispanic and Latino communities and do testing. I mean, testing at 1 and 2 o'clock in the morning. And so rather than waiting for those groups to come to us and put out all of the literature and expect that someone's going to show up from 8 to 5, we took testing to those communities. We don't have the capacity to do that from our standpoint in our office, but we do have a number of organizations that we fund that have a mobile clinic. We have a partnership with the Community Health Association of Mississippi, which trains and works with community health workers in the community. And with our Community Health Worker Initiative and our partnership with them, as well as with HRSA, we are hoping to use them as messengers in the community to reach those groups that we're having a hard time bringing out. So we have mobile testing, and one of the things I think we realized, at least from the health department standpoint, if we're going to do a blitz HIV testing, it needs to be part of something else. For example, COVID testing. If it's vaccination, it needs to be part maybe of glucose screenings. So it can't just be about HIV. And that's becoming the norm of thinking with other groups. It used to be when HIV was on everyone's mind, people were eager to get tested. People are still eager to get tested, but they don't want it to be the only thing that they're doing when they come in to receive a service. If we have a mobile clinic, they don't want that to be the only thing that they're receiving. We have a partnership, a collaboration with Plan A Health, and they are a mobile medical clinic on wheels. I happened to go on their clinic. They have exam rooms. They're able to do gynecological exams and family planning. And with that, part of what they're testing for includes HIV or syphilis, but it's a mobile medical clinic and it has nothing to do with STDs or HIV, although the testing is taking place. I just think as we try to reach those non-traditional communities or partners that we haven't necessarily embraced fully, we're going to have to be a little bit innovative and have partnerships and do work that we haven't considered yet. And so in that last slide where I had community engagement with the question mark, a lot of that, of what we need to learn and do, will come from the community that we need to serve.
Thank you so much to you both. And I know we're a little bit past time, but I think the conversation we were having was so incredible. We're so grateful for y'all's leadership. I think Mississippi is doing incredible things that deserves all the recognition, particularly with engaging with community and the work that you all are doing to ensure that people are getting what they need. So thanks so much to both of you all. We invite everyone who's joining us to join us for our roundtable. We'll be joined by some of the community groups that you all have heard about today. We'll be talking more about that. So thank you so much to both of you. Take care, everyone.
Thank you.
Thank you.